Good morning all. I think your valvular heart diseases have started. Today's topic is mitral stenosis. Please pay attention. What you learn in theory will be quite different from what you see in the clinical scenario, but as far as your clinics are concerned, mitral stenosis is a very important topic, okay? So I'll be covering it under the following subheadings. So I'll give you a little bit of introduction first, followed by epidemiology, 2 lines about the etiology, little bit about pathophysiology. I'll elaborate the clinical features, both the symptoms as well as signs. Then I'll tell you how to diagnose, what investigations are used. Then a few conditions which affect mitral stenosis, namely atrial fibrillation, pulmonary hypertension, and pregnancy, because those are the 3 important side subheadings in this topic. Then I'll cover some treatment and a list of complications. Okay. At the end, I'll give you a case scenario. We'll see if you can arrive at the diagnosis or not at the end of this class. Okay. So introduction, mitral stenosis is a fairly common valvular heart disease. It's a common valvular lesion which causes substantial morbidity worldwide. Okay, it's most commonly associated with rheumatic fever, rheumatic heart disease. Rheumatic heart disease, you've already had a class, I believe. This is prevalent among developing countries because of poor hygiene, because of overcrowding. Rheumatic heart disease, it's an infectious disease, so it's more prevalent among developing countries. So among the younger population, mitral stenosis as a result of rheumatic fever is seen in developing countries. However, it's also prevalent among developed countries, that is Western countries, the more richer countries. Okay, so there you see mitral stenosis as a result of age and comorbidities like hypertension and coronary artery disease. Okay, older people will also have degeneration. They'll have valvular degeneration, valvular calcific degeneration, as a result of which they may develop mitral stenosis. Okay. Bit of history. The disease was first described by Vucens in the year 1705. It was the first disease to be diagnosed by echocardiography, and it was also the first valvular lesion to be treated by surgery successfully. Epidemiology, the prevalence in a US-based survey was found to be 0.1%. 9% of single valve diseases in the European Heart Survey was found to be attributed to mitral stenosis. However, in developing countries, there is a higher prevalence of rheumatic heart disease. Just to give you a perspective, 6 in 1,000 school children were found to have rheumatic heart disease, as opposed to only 0.5 in 1,000 group school children in developed countries. So, among patients who have rheumatic heart disease in India, at least 40, minimum of 40 to 60% of patients were found to have mitral stenosis. So the disease is said to have malignant progression, frequently needing intervention in the teenage years itself. Okay. So etiology, 3 broad subheadings have been mentioned. The first is rheumatic fever, rheumatic etiology. The second is degenerative causes due to old age. And thirdly, you have other rare causes. So in rheumatic fever, because of the pathophysiology, you have a persistent inflammation going on within the valves, okay, due to which there is valve damage. There is also hemodynamic injury, because there is a gushing flow of blood. When you have a stenotic valve especially, your blood will try to flow through with increased force, as a result of which there may also be valvular injury. And thirdly, rheumatic fever is not a once in a lifetime event. There will be repeated episodes of rheumatic fever, especially if the patient is at risk. Okay, so these are the causes for mitral stenosis developing in rheumatic fever. Degenerative causes seen more frequently in the elderly patients, in the dialysis dependent patients, patients who have calcific stenosis, calcific degeneration, severe mitral annular calcification, resulting in mitral stenosis. Other rare causes, you have congenital causes like parachute mitral valve. You can also have double orifice mitral valve, You can have infiltrating diseases like mucopolysaccharidosis and sarcoidosis. You can also have multisystemic diseases like Fabry's disease, systemic lupus erythematosus, and rheumatoid arthritis. Lastly, in post-mitral valve repair, having repaired the mitral valve, there is a chance of restenosis because of continuing inflammation. Okay, so these are the other rare causes. This is the etiology. Coming next to the pathology. Your normal mitral valve area is 4 to 6 centimeters square. Okay. At when you have mitral stenosis, the stenosis occurs slowly. It doesn't suddenly stenose overnight. Okay, so your stenosis happens at a rate of 0.1 to 0.3 centimeters square per year. Okay, so at some point your valve area will decrease from a normal of 4 to 6 centimeters square to about 2 centimeters square. So when it becomes when it reaches an area of 2 centimeters square, the patient may slowly develop symptoms. Okay, so as the valve area decreases, there is an increased pressure gradient across the left atrium to the left ventricle. Okay, because a higher pressure gradient is required in order to force the blood via the stenotic valve. So at a significant obstruction of 2 centimeters square, the blood flows from left atrium to left ventricle only if propelled by an elevated atrioventricular pressure gradient. Okay, so this increased atrioventricular pressure gradient is the hemodynamic hallmark of mitral stenosis, and this is also the cause of dyspnea. Okay, so symptom onset when the mitral valve area reaches 1.5 centimeters square. The first bouts of dyspnea, the first initial onset, is precipitated by any clinical events that either increase the cardiac output or increase the rate of blood flow across the mitral orifice. In rheumatic mitral stenosis, because it's an inflammatory process, you have chronic inflammation, which results in thickening of the leaflets, formation of nodularities on the leaflet surface, and also commissural fusion, resulting in the narrowing of the valve and also results in a fish mouth appearance. Here you can see the comparison between the mitral valve morphology and the fish mouth. Okay, this fish mouth is also called as buttonhole appearance. So along with the mitral, the commissural fusion and the narrowing of the mitral valve, you will also have caudal fusion and shortening, resulting in increased resistance to blood flow. That's about rheumatic mitral stenosis. In addition to the valve itself, you will also have compromised systolic and diastolic function. LV diastolic function is a result of internal constraint from a rigid mitral valve. There is reduced preload, resulting in a reflex increase in afterload, resulting in LV systolic dysfunction. Diastolic dysfunction is because of abnormal chamber compliance. There is increased left ventricular end diastolic pressure. There's also pulmonary hypertension and reduced right ventricular pressure. This results in diastolic dysfunction. Apart from systolic diastolic dysfunction and abnormal valve morphology, there are also coagulation abnormalities. There are changes in platelet activities. There are increased increased fibrinopeptide A levels, increased thrombin, antithrombin 3 complex levels, increased D-dimer levels. All of these result in increased tendency for hypercoagulability, result in clot formation, which may embolize and cause thromboembolic episodes. The stenotic mitral valve behaves like a fixed orifice in spite of changes in the pressure in the left atrium, in spite of changes in flow and pressure. Patients with severe mitral stenosis have little functional reserve. So even a small decompensation will result in the patient developing symptoms like breathlessness and going into decompensation. So patients with severe mitral stenosis have little functional reserve. They easily decompensate as a result of tachycardia or conditions causing high flow across the mitral valve. Just before they go into decompensation, patients will have some amount of compensatory mechanisms in the form of pulmonary hypertension, dilated lymphatic vessels, and thickened alveoli. So these compensatory mechanisms may offset the onset of symptoms for a short period. But as these are compromised, as these compensatory measures become overwhelmed, patient will eventually become symptomatic. The clinical presentation, there is a latent period of at least 20 years in between the first attack of rheumatic fever and the onset of the presentation of the patient with symptoms of mitral stenosis. So this is called the latent period, and it lasts 2 decades. So from your rheumatic fever class, you know that the onset is quite early in life. So patients usually are diagnosed with rheumatic fever by the age of 10 years, 11 years. Okay. So symptom onset takes about 20 years to develop. So usually the patient, by the time he or she presents, is in the 4th decade of life. However, once the patient's symptoms become quite severe, patient presents with breathlessness at rest, patient has edema, patient has orthopnea and PND. These are quite severe symptoms heralding heart failure. Once there is onset of severe symptoms, it takes about 2 to 5 years for the patient to decompose, to quite rapidly deteriorate and die. Dyspnea and cough develop due to marked elevation of left atrial pressure. This can also be precipitated by a sudden change in the heart rate or volume status or cardiac output. So conditions which precipitate the sudden change in heart rate can be severe exertion or emotional excitement, or systemic conditions like fever, severe anemia, paroxysmal atrial fibrillation, even sexual intercourse. Pregnancy is a cause of high cardiac output. Even thyrotoxicosis, you have increased heart rate as well as high cardiac output. So when you have a patient presenting with breathlessness, you have determined to be of cardiac origin from the history. You have to ask what is the precipitating feature. Okay, so you have to ask if the breathlessness is exaggerated during exertion or excitement, or if the patient was febrile, or you have to ask for symptoms suggestive of anemia. Okay, so this point is important when you take your history. So the first symptom is dyspnea. So as mitral stenosis progresses, lesser and lesser degrees of stress, physical or emotional, will precipitate exertional dyspnea. Okay, so this over a period of time results in limitation of daily activities. So your NIHA classification is important. You have to know what extent of exercise precipitates the dyspnea, what was the extent initially, and what is the extent of exercise now which precipitates dyspnea. So as I mentioned before, the valve area narrows every year by about 0.1 to 0.3 centimeters square per year. However, when you're in developed countries especially, recurrent episodes of rheumatic fever will accelerate the course of your disease. Okay, so what disease progression normally occurs over the course of 20 years, this natural progression can be compressed by a duration of 5 to 10 years when you have a patient with recurrent rheumatic fever. So once the patient becomes dyspneic, over a course of time, patient also develops orthopnea and PND because of right heart failure. When you have age-related comorbidities like hypertension, diastolic dysfunction, coronary artery disease, diabetes, dyslipidemia, these symptoms can again be precipitated earlier in the presence of age-related comorbidities. Your second symptom is hemoptysis. Hemoptysis in mitral stenosis is a result of rupture of pulmonary bronchial venous connections. This happens as a result of increased pulmonary venous pressure, pulmonary venous hypertension. Other causes are increased cough because of increased dry cough, which can result in hemoptysis if the coughing is too forceful. You can also have hemoptysis in the form of pulmonary blood-stained sputum, as in pink frothy sputum. When you have heart failure and pulmonary edema, you can have pink frothy sputum. However, that is not frank hemoptysis, it's just a differential diagnosis. So hemoptysis results from rupture of pulmonary bronchial venous connections. Then you have chest pain. Chest pain is a result of pulmonary hypertension. It occurs as a result of exertion along with dyspnea. Then you have pressure effects. Pressure effects are as a result of dilated as an enlarged right atrium. So when your valve area is quite small, right? This should be left atrium. I'm very sorry. This should be left atrium. So when your valve area is quite small, you'll have enlargement of your left atrium first, followed by right ventricular enlargement, followed by right atrial enlargement. So as a result of this biatrial enlargement, patient will have a pressure effect wherein the atria will compress either on the esophagus, resulting in dysphagia, or on the trachea, resulting in dyspnea, or on the recurrent laryngeal nerve, resulting in hoarseness of voice. So hoarseness of voice as a result of pressure effect from enlarged atria is called as Ortner's syndrome. Then you have pulmonary features. Your patient can present with repeated pulmonary infections in the form of bronchitis, bronchopneumonia, lobar pneumonia, especially precipitated during the winter season. There will also be changes in pulmonary vascular bed. There will also be alveolar thickening. There will be a functional compromise in the pulmonary function. Okay, so you will have reduced vital capacity, reduced total lung capacity, reduced maximal breathing capacity, and reduced oxygen uptake per unit of ventilation. So this is your pulmonary effect. Lastly, you'll have thromboembolic events. Okay, so as a result of left atrial enlargement as well as atrial fibrillation, during atrial systole, your blood is not effectively transferred, effectively passed into the left ventricle. Okay, as a result, there will be pooling of blood within the left atrium, during which time thrombi may form within the left atrium, both as a result of pooling of blood, as well as atrial fibrillation, as well as your procoagulant pathophysiology, which I discussed earlier. So once you have thrombi within the left atrium, you will see an incidence of systemic embolization in about 10 to 20% of patients. This frequency of embolization increases in patients who have atrial fibrillation, older patients who have who are aged more than 65 years, and patients who have decreased cardiac output. It could be as a result of other causes like coronary artery disease, maybe hypothyroidism, and so on. So thromboembolic events in mitral stenosis may often be the presenting symptom. So patient may be asymptomatic, patient may never have an episode of dyspnea, patient may never have an episode of dry cough or winter bronchitis, but patient with mitral stenosis which goes undetected and undiagnosed may present with an event of thromboembolism, either a CVA or an MI or a pulmonary embolism or a mesenteric ischemia as a result of embolism. So this may be the presenting feature in otherwise asymptomatic MS, mitral stenosis. So death in patients with mitral stenosis is either because of congestive heart failure or because of systemic embolism. So your symptoms have been covered. I've discussed dyspnea. I've discussed along with dyspnea, patient will also have easy fatigability. Patient can have hemoptysis. Patient will have cough. Patient will have thromboembolic events. Okay. Then patient can also have chest pain and compression, pressure effects as a result of biatrial enlargement. So your symptoms have been completed. Coming to the signs. In general examination, you may see a malar flush. Malar meaning the area below your eyelids. Okay, so lower eyelids. Okay, so this is called malar area across the cheeks. So malar flush is seen along with pinched blue faces as a result of low cardiac output. When you see the pulse will be low volume because it's a stenotic lesion, right? So your cardiac output is compromised. You may also see an irregular pulse in case the patient develops atrial fibrillation. Blood pressure may be normal, but is also found to be low because it's low output lesion. Then when you see the JVP, you can see prominent A waves because of vigorous right atrial systolic pressure. Vigorous right atrial systole in case of pulmonary hypertension or coexisting tricuspid stenosis. Then in your cardiovascular examination, patient will have a tapping apex. Diastolic thrill may be felt in the left lateral position. Usually your diastolic murmurs are not palpable. Your palpable murmurs are usually systolic, but in diastolic also you can feel a thrill. Okay. Then RV tap or right ventricular heave, parasternal heave may be felt in the left sternal border because of enlarged right ventricle. On auscultation, you will have an accentuated S1, that is a loud S1. This is as a result of increased blood flow, increased high volume of blood flow across the stenosed mitral valve results in an accentuated S1. Okay, accentuated P2 is also heard. Your loud P2 which is closely split is heard over the pulmonary area. This is as a result of pulmonary hypertension. Apart from your accentuated S1, you will have an extra heart sound called as opening snap. Opening snap is a result of sudden tensing of the caudate tendineae. Okay, this occurs around 0.05 to 0.12 seconds after the S2. So your S2. First you have a loud S1 followed by your S2. This is, I'm talking about the mitral area. You have a loud S1 followed by an S2 followed by an opening snap. This is heard over the apex, heard loudly during the expiration. After the opening snap, you will hear a diastolic murmur. Okay, so you will hear a low-pitched rumbling diastolic murmur with presystolic accentuation. So can you see this? You can see the diagram here. This is your S2 in your. I'm sorry. The large line is your S1. The small line is your S2. The red line is your opening snap, which is as a result of tensing of the caudate tendineae. After the opening snap, you will hear your mid-diastolic murmur, which is low and rumbling in nature. In case of severe mitral stenosis, you can also have presystolic accentuation. That is, after your murmur disappears, it starts in the mid-diastolic time frame, and it should ideally disappear before the onset of S1. However, in severe mitral stenosis, you will also have presystolic accentuation. That is, your murmur becomes loud just before the onset of S1. Okay, but in severe mitral stenosis, especially in patients with atrial fibrillation, your presystolic accentuation is lost because your heart rate is quite irregular. So you can't really make out which is S1 and S2. You have to time it with the carotid pulse, and you can't really make out presystolic accentuation because the rate is quite irregular. So you have a low-pitched rumbling mid-diastolic murmur with presystolic accentuation heard over the apex with patient either in recumbent, that is lying down flat, or in the left lateral position at end of expiration. Okay. Please be careful when you have a patient with suspected mitral stenosis. You have to examine the patient in left lateral position. Okay. Even if you can hear the murmur in the recumbent position, please make your patient lie down in the left lateral position and examine, because most examiners are very particular. When they come to take your case, they'll ask the patient whether you made them lie down in the left lateral position and examine them or not. So please do this for all cardiovascular serious cases, because when you can miss a mid-diastolic murmur in the recumbent position. This is often picked up when you put the patient in left lateral position. So the severity of mitral stenosis is determined by the gap between S2 and the opening snap, as well as the duration of the murmur. So the more severe the mitral stenosis, the shorter the gap between A2 and opening snap. Also, the more severe the mitral stenosis, greater the duration of the mid-diastolic murmur. One thing about this opening snap, because it occurs just after your S2, it can be confused with the splitting of your second heart sound. Okay, so you know that your second heart sound is heard in two components over the pulmonary area. Okay, so you get your A2 followed by the P2 in pulmonary area. However, your opening snap is heard more clearly. It's heard only over the mitral area, whereas the splitting of your second heart sound is heard over the pulmonary area. So this is this sound is heard over the apex, whereas splitting of second heart sound is heard over the base. So when you have a patient with heart failure, you can also hear additional heart sounds like S3 and S4. So this is as far as auscultation is concerned. Additional features, both in general and systemic examination. When you have a patient with heart failure, you'll have features like dependent edema, ankle edema. Patient can have ascites, patient can have pleural effusion, most commonly right-sided pleural effusion. Patient can also have bilateral basal crepitations when you examine over the respiratory system. Other associated lesions, patient can have a functional tricuspid regurgitant murmur as a result of severe pulmonary hypertension. You have something called a Carvalho sign, wherein this tricuspid regurgitation murmur becomes louder during inspiration and diminishes during forced expiration. In silent MS, silent mitral stenosis, you have a markedly reduced cardiac output. You will not hear an opening snap because your chordae tendineae and your leaflets are not as pliant anymore. So this is called silent MS in case of severe disease. Then you can also have a Gram-Steele murmur. Gram-Steele murmur is a murmur of severe pulmonary hypertension. So you'll have a high-pitched diastolic decrescendo blowing murmur heard along the left sternal border. This is heard due to dilatation of the pulmonary valve ring and is seen in pulmonary hypertension. So coming to investigations and diagnosis, you do an ECG, you do an echo, both transthoracic echo as well as transesophageal echo. You can also do a cardiac CT, a cardiac MRI. In addition, you can do a stress test or exercise 2D echo. Okay. So in sinus rhythm, the patient will have features of left atrial enlargement. This is seen in the form of P mitral. Okay. So the width of your P wave, this is seen most clearly in the second in lead 2. Okay, so your width of the P wave will be greater than 40 milliseconds or more than 3 small squares, and your P wave, instead of being a smooth wave, will have a notch at the peak. So this is called as P mitral. This is a feature of left atrial enlargement. When you have severe pulmonary hypertension or accompanying tricuspid stenosis, you'll see a tall peaked P wave. This is seen in lead 2. You can also see right axis deviation as a result of pulmonary hypertension, and you can also see right ventricular hypertrophy. So right axis deviation, how will you make out? Just very generally, broadly speaking, in right axis deviation, your QRS complex will be negative in the lead 1 and it will be positive in the lead AVF. Okay. Then right ventricular hypertrophy is seen in the form of a persistent S wave, even in leads V5 and V6. Then coming to echocardiogram, you do a transthoracic echocardiogram with color flow and spectral Doppler. Through a transthoracic echo, you can make out mitral inflow velocity during early and late diastolic filling. You can make out the mitral orifice area. This is used to prognosticate and opine on the severity of the mitral valve disease. Presence of coexisting valvular lesions like associated mitral regurgitation, associated tricuspid stenosis or regurgitation, associated aortic regurgitation. Because when you have a patient with rheumatic heart disease, you can either have a single valvular disease in the form of pure mitral stenosis, pure mitral regurgitation, or you can have multivalvular involvement. So 2D echo is crucial for picking up these lesions. Then you can see the extent of leaflet calcification and the extent of restriction of movement. You can see the degree of distortion of subvalvular apparatus, that is your papillary muscles and chordae tendineae. Then you can also assess the left ventricular and right ventricular function, and you can also opine on the chamber size. Transesophageal echocardium is crucial if you're planning a percutaneous balloon mitral valvuloplasty in order to rule out left atrial thrombus. So this is your left atrium, this is your stenotic mitral valve, this is your left ventricle. Okay, so that's your echocardiogram. Based on the echocardiogram, you can diagnose the severity of MS. Okay, so mild, moderate, and severe MS. When you have a mean atrial pressure gradient between the left atrium and the left ventricle, when your pressure gradient is less than 5 millimeters of mercury, it is mild. 6 to 10 millimeters mercury, it is moderate, and severe when it is more than 10 millimeters mercury. Also based on your valve area, when you have a valve area of 1.6 to 2 centimeters square, it's said to be mild. 1 to 1.5 is said to be moderate. Less than 1 centimeter square is severe mitral stenosis. This is also called as critical stenosis. Then in your chest X-ray, you'll see quite a few features. First of all, because of left atrial enlargement, you'll see the straightening of the upper left border of the heart of the cardiac silhouette. Then you can see prominent pulmonary arteries. You'll see your obliteration of the pulmonary bay over here. You can also see prominent pulmonary veins in the upper lobe. Posterior displacement of esophagus due to the enlargement of left atrium. This you can't make out on PA view. You have to do a lateral view X-ray. Then you finally you have something called curly B lines. So curly B lines are fine, dense, opaque horizontal lines, which are seen in the lower or mid lung fields. This happens as a result of distension of interlobular septae and lymphatics, resulting in edema. When your resting left atrial pressure is greater than 20 millimeters of mercury. So these are your curly B lines, just to give you an idea of where to look. These are horizontal dense lines, which are seen in the middle and lower lung fields. So other investigations you can do are exercise echocardiography, dopamine stress test, cardiac CT, and cardiac MRI. So differential diagnosis are left atrial myxoma. These are all basically causes of compromised left atrial outflow. Okay, so other differential diagnosis are left atrial myxoma, cor triatriatum, ball valve thrombus, and atrial septal defect. Atrial septal defect also, you have a loud S1, you have a mid-diastolic murmur, which is accentuated during exercise. The difference is made out when you do a 2D echo. Okay. In left atrial myxoma, patient will also have systemic symptoms like weight loss, fever, associated anemia, elevated levels of IgG, and interleukin 6. So conditions affecting mitral stenosis. I'll be talking about 3 conditions. First one is mitral atrial fibrillation. Second one is pulmonary hypertension. Third one is pregnancy. Okay. So atrial fibrillation develops around 10 to 15 years after the onset of mitral stenosis. This is caused by atrial inflammation and remodeling of the endothelium. So this is seen in about 40 to 75% of patients who are symptomatic for mitral stenosis. Often the onset of atrial fibrillation itself precipitates the symptom, precipitates the clinical symptoms, and results in the diagnosis of mitral stenosis. Atrial fibrillation is associated with high risk of systemic embolization. Due to atrial fibrillation, your atrial contraction is both irregular as well as not strong enough. Okay, the intensity of contraction is quite irregular. Okay, so as a result, this reduces the cardiac output. As a result, there is reduced exercise capacity. Patients who have mitral stenosis with atrial fibrillation on undergoing percutaneous balloon valvotomy can revert to normal sinus rhythm. If this is done in patients who have a left atrial diameter less than 45 millimeters and patients who have had a duration of atrial fibrillation less than 1 year. Pulmonary hypertension is often found in symptomatic patients of mitral stenosis. This is one of the compensatory mechanisms that I mentioned in order to offset the symptoms. This has both prognostic implications and triggers the need for therapeutic interventions. The onset of pulmonary hypertension is mediated by mechanical factors, vascular remodeling, as well as endothelial factors. So this is also readily reversed with surgery or percutaneous balloon valvuloplasty. Pregnancy, mitral stenosis is one of the most common lesions which are detected during pregnancy, valvular heart lesions. This is diagnosed usually at the end of during your second trimester. This is when your volume expansion happens, your cardiac output increases, patient will usually go into failure as a result of increased cardiac output, especially in the presence of valvular stenosis. So symptoms are precipitated due to changes in the blood volume in the second trimester. In pregnancy, mitral stenosis is associated with significant morbidity. Complications will correlate to the NIHA class as well as the age of the patient. Better outcomes are seen with early aggressive management as opposed to medical management and taking it slow. So when you have a patient with mitral stenosis in pregnancy, you want to be aggressive. Even better if the lesion is picked up before the pregnancy, then you can do a percutaneous balloon valvuloplasty. You can mechanically correct the lesion and then plan a pregnancy. So fetal complications in mitral stenosis in pregnancy are IUGR as well as premature labor. Medical treatment is not as effective as surgical or interventional treatment. So what you want to do is you want to slow down the heart rate, especially in the presence of atrial fibrillation. You want to control the heart rate so that the left atria has more time to pump blood across the mitral valve. So you slow down the heart rate using either calcium channel blockers like verapamil and diltiazem, or beta blockers like atenolol, bisoprolol. However, in pregnancy, beta blockers are contraindicated because they can lead to IUGR. Okay, then you want to treat the atrial fibrillation. You can use cardiac glycosides to control the rhythm. You also want to use anticoagulants because, as I mentioned, when you have a patient with atrial fibrillation as well as mitral stenosis, there is increased chance of thrombus formation in the left atrium. Okay, so when you have atrial fibrillation, there is increased risk of this thrombus getting dislodged and leading to thromboembolic events. So you want to avoid that by using anticoagulants like warfarin. Okay, so whatever warfarin, apixaban, dabigatran, these are all anticoagulant agents which are being used right now. When you use an anticoagulant on a patient with valvular heart disease, your target INR should be in between 2 to 3. Okay, then be gentle with diuretic use. Diuretics are usually used when you have a patient with breathlessness. To relieve the breathlessness, you can also use nitrates to relieve the breathlessness. But you have to be careful when you use diuretics, okay, because it's a stenotic lesion. You don't want to when you use diuretics, you don't want to decrease the BP too much. Okay, so be cautious with the use of diuretics. And lastly, correct the secondary causes that precipitated the symptoms. So when you have a patient with anemia, you can either give a blood transfusion along with diuretics. When you give a blood transfusion, the patient will go into fluid overload, right? So then you can give diuretics. So correct the anemia, control the fever, control the volume overload, correct the infection. Okay, so this is as far as your medical treatment is concerned. Then coming to surgical treatment, 4 modalities. Okay, so open valvotomy, wherein you can do a controlled reconstruction of the valve. When you do an open valvotomy, you have a view of what you're doing. Okay, so there is you can do a controlled reconstruction of the mitral valve. You can also simultaneously repair whatever other valves have been affected, like tricuspid valve, aortic valve. But when you're doing an open valvotomy, you have to have the support of a cardiopulmonary bypass. Then closed valvotomy is done through either transatrial or transventricular approach. Then mitral valve replacement is the last resort. It can be done in children or young adults who are planning pregnancy, or in very old adults. Okay, elderly patients. Then lastly, you have percutaneous balloon valvuloplasty. So this is the treatment of choice, and it has been ever since 1995. In this procedure, a dilating device is passed either antegrade or retrograde. So antegrade, it is passed through the atrial septum. Retrograde, it is passed via the aorta. Okay, so this dilating device is passed across the mitral valve. Once it enters the mitral valve, the balloon is inflated. Okay, so this inflated balloon across the mitral valve will result in a widening of the mitral valve area. So dilatation will split the commissures and results in a clinically significant improvement. Okay, so at the end of your percutaneous balloon valvuloplasty, the mitral area will increase by increase to an area of 1.5 centimeters square. So coming to the natural history of the disease, usually the disease takes up to 20 years to manifest, and after the symptoms become severe, patient can progress to death within 2 to 5 years. But in countries with recurrent bouts of rheumatic fever, in developing countries, patients will see a rapid progression of the disease. Effective treatments that can improve the valve area will reduce both morbidity as well as improve the survival. Despite improvement in symptoms with percutaneous balloon valvuloplasty, re-intervention may be needed, okay, because of re-stenosis or because of recurrent bouts of rheumatic fever. If the patient is not taking adequate prophylaxis against rheumatic fever, patient may again develop mitral stenosis requiring re-intervention. There is varying incidence of recurrence of complications even following percutaneous balloon valvuloplasty. When intervention is needed, balloon valvuloplasty is preferred over surgery, as it is both more economical and is associated with less morbidity. So this is your natural history. Finally, the complications. Complications are atrial fibrillation, systemic embolization in the form of CVA, pulmonary embolism, mesenteric ischemia, pulmonary infarct. Okay, congestive heart failure, pulmonary infarct I've mentioned, hemoptysis, recurrent lung infections, endocarditis, and Ortner syndrome. Ortner syndrome is hoarseness of voice due to compression of the recurrent laryngeal nerve by the enlarged left atrium. So I'll give you a case scenario. You can think about this later. When you have a patient, this is how you have to take the history. Just pay attention. So a 40-year-old female presents with 3 months history of worsening exertional breathlessness along with easy fatigability and dry cough. So these are the chief complaints. Coming to the history of presenting complaints, illness, I'm sorry. The breathlessness was initially noticed while performing strenuous exercise. Okay. So that is grade 2 or grade 3. I'm sorry, class 2 or class 3. When you're presenting a case of breathlessness, from your symptoms, you have to decide whether it's a pulmonary case or a cardiovascular case. Okay. So if you're suspecting a pulmonary case, you present your severity of breathlessness in the form of grades. That is your MRC grading. If you're suspecting a cardiovascular disease, you have to present your severity, your NIHA classification. So breathlessness was initially noticed while performing strenuous exercise, but since 1 week, the patient is breathless even on mild exertion. So the breathlessness has progressed from class 1 to class 3. She also complains of easy fatigability and dry cough for the same duration with blood-stained sputum on 1 occasion. She denies other cardiorespiratory complaints. So what other cardiorespiratory complaints will you ask about? You'll ask about any orthopnea, you'll ask for any PND, you'll ask for history of palpitations, you'll ask for any chest pain. You can also ask for syncopal attacks, okay? Any giddiness or syncope. You can also ask for any features of fluid overload like edema. Okay, so patient denies other cardiorespiratory complaints. You can also ask for history of wheeze and other systemic symptoms like fever and weight loss. So this is your history of presenting illness. Coming to the past history, she suffers from episodes of cough and breathlessness, especially during the winter season, which is being treated by her primary physician with the use of bronchodilators and cough syrup. On her last visit, however, her primary physician referred her to a cardiologist who diagnosed a valvular heart disease and started the patient on tab phenoxymethyl penicillin, BD. In the past history, the patient gives history of an episode of fever with breathlessness at the age of 11 years, which was treated symptomatically, and patient was not evaluated further. So there's nothing significant in her personal history, her family history, but based on this chief complaint of exertional breathlessness, easy fatigability, and dry cough along with hemopresis, you have to take a detailed you have to take a detailed history of presenting illness. You have to analyze the past history and you have to arrive at a diagnosis, a provisional diagnosis at least. Okay, so from this history you have to decide whether it's a pulmonary, whether it's a respiratory case, or whether it's a cardiac case. Here in the past history you have a clue in the form of a cardiovascular, in the form of a cardiology consultation. Patient is taking phenoxymethyl penicillin. So phenoxymethyl penicillin is given in rheumatic heart disease. Patient also gives history of an episode of fever with breathlessness, which likely points to rheumatic heart disease. So, at the end of this history, I would give a provisional diagnosis of breathlessness for evaluation, likely to be of cardiovascular cause, suspecting valvular heart disease in view of rheumatic heart disease. Okay, so this would be your provisional diagnosis. You can, where your examiner will ask you why it's not a respiratory disease, why it can't be TB, why it can't be bronchial asthma, why it can't be IHD. Okay, so you have to have, why it can't be IHD? Patient is quite young. Okay, so there's no chest pain as such. Your rheumatic heart disease starts early in life and your symptoms are precipitated in the fourth decade. You have to consolidate whatever diagnosis you're giving, you have to defend it based on your history. So there's a lot of scope for discussion based on the history itself. This is just an outline of how you have to present your cardiovascular case. Then coming to general examination, patient has pallor, pulse is 70 beats per minute, regular, low volume. There is no, regular and low volume. There's no delay either. The blood pressure is 100 by 60 millimeters of mercury in the right arm supine position. Respiratory rate is 20 per minute. Patient is afebrile. So this is your general physical examination. In addition to this, when you are suspecting a cardiovascular case, you also have to look for pointers of infective endocarditis. Okay, you have to mention that there are no features of infective endocarditis, especially in a cardiovascular disease. You also have to look for features of Marfan's disease. Okay, like you have to look for the arm span, you have to look for high arched palate, you have to look for lens dislocation, because in Marfan's disease, patient will frequently present with mitral valve prolapse or regurgitant lesion. So these two things you have to comment in your general physical examination. Then coming to the systemic examination, on inspection, the apex is visible in the left fifth intercostal space, right over the mid-clavicular line. On palpation, apex is confirmed to be in the left fifth intercostal space, found to be tapping in nature. Palpable P2 is felt in the left second intercostal space. Left parasternal heave is also present. You have to mention the grade of the left parasternal heave. And on palpation, diastolic thrill is felt over the mitral area. Okay. On auscultation, loud S1 is heard in the mitral area. Opening snap is heard soon after S2. A mid-diastolic murmur of grade 4 by 4. Your systolic murmurs will have 6 grades, diastolic only have 4. Okay, a mid-diastolic murmur grade 4 by 4, which is low-pitched and rumbling, heard over the mitral area in left lateral position at peak expiration is present. In the pulmonary area, there is a loud P2 with fixed narrow split, and ejection systolic murmur is also heard over pulmonary area. So this is your examination. Your other systems are all normal. I didn't mention them, but based on this history and based on this examination, what is your provisional diagnosis at the end of history? What is your final diagnosis at the end of examination? What investigations would you like to do on this case? And write a note on the treatment of rheumatic fever. So take this as a bit of homework. Mitral stenosis is very important from your examination, from your clinic's point of view, but in theory they'll ask you either about rheumatic heart disease or they'll ask you about infective endocarditis. Okay, so please be thorough. Please, if any of you have Littman's tests, you'll get a CD with all your heart sounds. So please listen to the mid-diastolic murmur. It's quite hard to pick up. Okay, so I think this is it. This is the end of your class. Thank you for your attention.